Afternoon and welcome to the Flint Community Webinar. This is your community resource every Friday at noon. We're so very grateful that you are here with us. We have an amazing lineup. I almost forgot to introduce myself. My name is Heatherlyn Uphold. I'm an assistant professor with Michigan State University here in Flint with the CS Mott Department of Public Health. This week, here's our lineup. So we're starting off with some folks from Gift of Life, Michigan, talking about Donation 101. We have Shalonda Griffin. She's the community relations coordinator with Gift of Life, as well as Sonia Cook. You do not want to miss the story that she's going to share and the information that these two will be sharing as well. We have Nurse T. She's going to give us some kidney health awareness 101. I've seen her slides. You don't want to miss it. There's some great information there. If you don't, and recall a couple months ago, I think it was, we had Dr. Caitlin Learoff with us. She's from Hurley and she's an infectious disease physician. She talked to us about sexually transmitted infections. And I tell you what, when she was on, we ran to 1 o'clock and then went past 1 o'clock and we just kept going with the conversation. But what we didn't get to are your questions. And we know that that's a really important part of the webinar. So we invited her back the first chance that she could join us, and she's here and she's going to be talking to us. But let's bring up Shalonda. She's going to be talking to us about Gift of Life and all of the things that we need to keep in mind with that.
All right. Good afternoon. Thank you so much for having me today. I really appreciate this opportunity. So thank you very much. As you mentioned, my name is Shalonda Griffin, and I am a community relations coordinator for Gift of Life Michigan. For those who might be unfamiliar with Gift of Life, we facilitate organ and tissue donation. So we serve as a bridge between those people who are waiting for life-saving transplants and transplant centers. And a big part of my job involves community education. I'm based here in the Flint area. I also do some things in the Saginaw Bay counties as well, but I spend a lot of time presenting to high schoolers because they're going to be asked the question, would you like to join the Michigan Organ Donor Registry when they receive their driver's license? And there is a ton of misinformation about donation out there. And I don't want these students or even the adults that I talk to in the community to depend on this week's episode of Grey's Anatomy when it comes to making such an important decision. So I'm going to go over some of the basics of organ and tissue donation and share a little bit about my organization. And then I'm going to introduce one of our ambassadors, Ms. Sonia Cook. She is a kidney recipient, and she's going to just share her amazing story with us about how donation literally changed her life. So I'm going to go ahead and share my screen. There we go. So just to let you all know a little bit about Gift of Life Michigan, we are the state's federally designated organ and tissue donor program. We're headquartered in the lovely city of Ann Arbor, and along with working with all of the residents of the state, we also work with 130 hospitals in 8 transplant programs. Every hospital obviously is not going to be a transplant program since there are only 8 of them. So here in this area, you're unable to go somewhere like a Hurley, a McLaren, a Genesis, and receive a heart transplant, a liver transplant. Now, a lot of the testing that you'll go through to find out if you are a good candidate, yes, you can go to those places. But when it comes time to actually receive that new gift, you're going to go somewhere like your U of M hospital in Ann Arbor or your Henry Ford in Detroit. Now, the majority of people who have already joined the registry, and that's about 56% of Michiganders, they sign up at the Secretary of State's office. 95% of people do. And the reason that they sign up there is because we have an official partnership with them. And the reason we have that partnership, pretty much everyone at some point in time is going to end up at a Secretary of State's office. So it only made sense for us to work with them. And I'm sure that you and all of our watchers know that when it comes to things like life and death, it doesn't matter if it's a weekend. It doesn't matter if it's after 5 o'clock. It doesn't matter if it's a holiday. So there's always someone working on behalf of Gift of Life Michigan 24/7, 365 days of the year. Now, what makes our organization pretty cool, and in my biased opinion, is we have a surgical center, and every OPO, which stands for Organ Procurement Organization, every OPO is not going to have that. Actually, there's only 3 OPOs in the entire country that do have a surgical center, and one of them just happens to be here in Michigan. Now, what that means is when a person passes away and it comes time to recover their organs, we can remove them from the hospital and bring them to our facility in Ann Arbor. Now, that might not sound impressive, but it is, and I will tell you why. Hospitals are very popular places within communities, right? They have all sorts of things going on, not just the recovery of organs. So by us being able to move that person from the hospital, they are able to free up an operating room at that facility, and the staff there can give their time and attention to whoever or whatever else needs their attention. And we can bring them to our facility where all we're going to focus on is the recovery of organs. And about 50% of donors do end up in our facility. Let me go on to the next slide. And just a little bit more about Gift of Life. Our core purpose is we honor life through donation, and our values are we are determined, compassionate, and professional. Now, just to give you all some statistics about donation here in the state, as of May 1st, over 2,300 Michiganders are awaiting life-saving transplants. And you can see that the majority of them are waiting for kidneys. Kidneys are the most needed and the most transplanted organ, not just here in the state, but across the country. And there are a variety of reasons for that. Sometimes people can have hereditary issues that can cause their kidneys to fail, but the number one reason is unmanaged diabetes, and the number 2 reason is unmanaged high blood pressure. But I'm sure Nurse T will get into that a little later in her presentation. Nationally, there are over 104,000 people who are waiting for transplants, and I don't want to call these fun facts, so I'll call them somber facts. About every 9 minutes, a new name is added to the national waiting list. So by the time we part ways today, about 6 new people will be added to that waiting list. And unfortunately, because we do not have enough organs to go around, about 17 people lose their lives every single day, which is tragic. I think the best way people can think about that is if you're familiar with the Big House in Ann Arbor, largest arena in the Western Hemisphere. The number of people in this country waiting for transplants would barely be able to fit into that facility, which is a shame. So organ procurement organizations like Gift of Life Michigan, as well as the other 55 that exist in this country, are doing everything that they can to make that statement a thing of the past. Our belief is no one in this country should have to die waiting for an organ transplant. Actually, I'm going to go back here. I'm going to share 2 real life examples for you. We have Miss Erin from the Detroit area. She received a liver transplant 12 years ago, and she is doing amazing. Erin's House of Hope, she's actually working on a home for transplant families. A lot of times when a family has to travel from point A to point B to get to that transplant center, housing, getting hotels, motels, those things cost money. So she is working on building a home where those families can stay while their loved one is receiving that gift at a very reasonable price. And then we also have Amaya here. Amaya is someone who needed a heart transplant. She received that transplant, but then she needed a second one. And unfortunately, that did not come in time, and she passed away at the age of 8, which is very sad. This little girl should have lived to see her grandchildren. So just another reason why organ donation is so very important. Now, one organ donor has the potential to change so many lives. So there are 8 life-saving organs that a person has the potential to donate, which means 8 people can have their lives saved. And when it comes to tissue transplant, 75 people or more can be healed. Over the last decade, more than 9,000 Michiganders have had their life saved due to transplant. And on average, about 90 people every single day in this country receive a new organ. And there are probably some people that you are familiar with in the media who are still here because of transplant. We have people like Selena Gomez, Tina Turner, Stevie Wonder, George Lopez, Tracy Morgan, Natalie Cole. Those are just a few people who are still here, still entertaining us because someone made that choice to say yes to donation. Now, I know that if you're someone who maybe you like Grey's Anatomy or Good Doctor, not to pick on all the medical shows, but they kind of make it seem like transplant is not that huge of a deal, right? So the main character will find out at 6 a.m. that they need a new heart. 5 p.m. rolls around, they've gotten that new heart. Everyone's going to the Bahamas in the morning to celebrate. But we all know that life is not as simple as a 60-minute ABC drama, which is unfortunate. But actually a perfect storm of things need to take place for a person to be considered a viable candidate. One of the most important things that needs to happen is that person would need to pass away in a hospital on a ventilator. And that ventilator plays a very, very vital role in the donation process, because that ventilator is going to allow oxygenated blood to continue to flow throughout that person's body, which in turn is going to keep those organs alive. I want you to think about this and why we have a deficit. About 90,000 people pass away every single year in this state. They pass away due to old age, accidents, pretty much anything you can think of. But only about 32,000 people pass away in a hospital. So we've got a deficit right from the get-go. Those people who pass away at home, they pass away in hospice care. Maybe they were in a car accident and they died on the scene. Those folks still have the potential to become tissue donors, which we'll discuss a little later, but they are not going to be medically eligible to be an organ donor. So that's why it's so important to get as many people as possible, not only educated, but on that registry, because everyone will not be able to donate their organs. Now, last year, we had 463 organ donors, which led to over 1,000 organs being transplanted, which is amazing. I think that as more people are learning about the difference donation can make, more people are deciding to become donors. I just received a work email just the other day saying for the month of April, we had 50 new organ donors, which is kind of a record for us, having 50 people in 1 month. So I know a lot of times we watch the news, we read the news, we see a lot of the bad going on in this world, selfishness and things like that. But there are a lot of selfless people out there who do make the choice to save someone else's life. And that's just so amazing and so important. Now, as I mentioned, there are 8 organs that can be transplanted. You have your heart. A person has 2 lungs, but not everyone is going to be in need of a double lung transplant. So those lungs can go to 2 different people. Same thing with kidneys. You have 2, but you can live with 1. Your liver, in some instances, can be split in 2. And what's cool about your liver is that it will regenerate or grow back to its original size. I like to call it the starfish organ. So that's kind of fun. And then you have your pancreas, and then you also have intestinal transplants. Like I said earlier, kidneys are the most transplanted organs, where intestinal transplants tend to be more of the rare type of transplant. Now, organ donation, as far as I'm concerned, is important in every single community out there, but it can be especially important in multicultural communities, because those communities tend to be more susceptible to things like high blood pressure, diabetes, things that could put them at risk for organ failure. And when I say multicultural, I mean Hispanic communities, Arab American communities, and African American communities. Here in this state, about 38% of people who are waiting, they're from multicultural communities. And nationwide, about 60% of people waiting are from those communities. Now, the one thing that I really like to stress is you can receive a transplant from anyone. They do not have to be the same race. They do not have to be the same gender. But your best match does tend to be someone who shares your same ethnic background, because you're going to have similar blood and tissue markers, and that is going to play a role in the matching of those organs. Also, the more closely an organ is matched, it will hopefully cut down on the risk of rejection. So when you receive a new organ, your body is going to say, the DNA of this organ is completely different from the DNA of everything else going on inside of me. So your body's instinct is to attack that new organ because it views it as as something that should not be there. Now, that's great if maybe you're a healthy person and you've picked up a cold virus. That's exactly what your body's supposed to do. Not so great if you're someone who has received a new liver. So along with that matching, recipients are also going to take anti-rejection drugs. And what those anti-rejection drugs are going to do is they're going to calm down or even almost wipe out that person's immune system so that their body does not attack itself, which will hopefully allow them to have a very long life with that new organ. We have a couple examples of some people here. Alina here on my left, she's right here from Flint. And she's had her liver for about 9 years now, and it's changed her life. So the more diverse we can keep that registry, the more lives can be saved. Now, I have found that certain communities can sometimes be very leery about joining the registry. And I get it. I understand that the medical community has not always been kind to certain communities. So sometimes people think it's a good idea, but they can be very nervous about actually getting that heart on that license. And the one thing that I hear across the board, no matter the community, is there is this fear that if you join the registry and you end up in the hospital for whatever reason, there's this fear that the medical staff is not going to save your life, which is absolutely untrue. People get into medicine to save life, to preserve life, but we live in an imperfect world. And sometimes after doing everything that they can, people still pass away. And that is the only time the topic of donation is brought up. And I actually want to share a video with you all, a very quick video from a mother of a donor who's part of a community that can sometimes be a little leery about donation. She's going to share her experience. Actually, she's going to share her experience in the next slide. I forgot about this one. So right here, this is just another slide that has the number of people who are waiting broken down by ethnicity. Once again, you can see the majority of those people are waiting for kidneys, but it also shows African Americans, Hispanics, and people from of Middle Eastern descent are the majority of people who are waiting. But you can also see at the top, it's May, and so far there have been 393 transplants, which is amazing because there are a lot of people who are still here because of that. All right, now we are going to get to that video. I'm going to go ahead and play that for you all. There we go. Maybe if my technology cooperates. There we go.
My son, Emilio Defoe, at the age of 18, became a registered organ donor. And we were
sorry.
Not, of course, expecting for him to give his gifts at the age of 24. One of the most common myths in the African American community is that doctors will not fight to save your life. And I know firsthand that that is not true because I watched doctors try to save my son's life. During the 10-hour heart surgery, they had to resuscitate my son several times. And so I take offense when I hear people say, you know, they don't want to become an organ donor because doctors won't try to save your life. They took an oath to try to save your life, and it has to stop because too many people are losing their lives because of this simple myth.
yeah, I think that is a very prevalent myth. I am usually pretty honest with people, and I tell them that, you know, my grandmother told me, don't join the registry when I went to the Secretary of State to get my license because of that same thing. There was this fear that if I ended up in the hospital, my life would not be saved. And it was my grandmother. I mean, she hadn't steered me wrong all this time. Why would I not listen to her? But I would encourage people to do their own research. Don't just take my word for it. I mean, we've got libraries, we got Google. Do your own research. Do whatever it is that you need to do to feel confident about the process. But I can say without a shadow of a doubt, like Dr. Defoe mentioned, people get into medicine to save life, not to take it away. We're going to switch gears a little bit. We're going to move on from organ donation and discuss tissue donation. Now, what's cool about tissue is, unlike organs, it's not going to save your life, but tissue transplant is going to greatly improve your life. It is going to help you with mobility issues. It's also going to help you with pain management. Last year, we had over 1,800 tissue donors. And I found that sometimes people have been affected by tissue donation and they aren't always aware of that. So let's say you've lost a tooth for whatever reason, and you've decided you're going to get a dental implant. Sometimes a doctor will use ground human bone and place it in that jawbone so that that dental implant has a more stable foundation. A lot of times people think that is a synthetic, you know, whatever, but it's not. It comes from an actual person. And when I talk about tissue, I'm talking about things like skin. Skin is generally used for people who have been burned, maybe someone who has had breast cancer and they've had a mastectomy. Their chest can be rebuilt with donated skin. You have tendons for ACL tears. Long bone is used a lot of times for people who maybe they've been diagnosed with bone cancer. Instead of having to have their arms amputated, for instance, they can remove that diseased bone and replace it with healthy bone. There's corneas that can be used to restore sight. Veins a lot of times are used for dialysis patients. You know, they'll have a fistula or graft in their arm. Most people do dialysis about 3 times a week for hours at a time. And the average wait in Michigan is 3 to 5 years for a new kidney. So that fistula or that graft is going to get a lot of work, and eventually those veins will go kaput and they'll need to be replaced. There's also heart valves, nerves, just so many things that can touch the life of someone else. So those are also some things to consider. So we've been discussing deceased donation, gifts one can give once they pass away, but you don't have to wait till you pass away to help save a life. There's also living donation. Like I said earlier, you have 2 kidneys, but you can live with 1. You can give a portion of your liver because your liver is going to regenerate. And you can also donate a lobe of your lung. Right here, we have a picture of Lynette. Lynette is from Goodrich, and she donated a kidney to a very close friend, and she was able to help save his life. A lot of times I have met living donors who will tell me that they forgot that they even had the surgery because they don't tend to have a lot of side effects. Well, granted, everyone's different, but the ones that I've talked to have not had any of those issues. Generally, after about a day or 2, they're released, they go back home. I had a gentleman who donated his kidney to his brother tell me the only reason he even remembers is because he has a small scar. So those are things that are not facilitated through Gifts of Life, but those transplant centers, your Henry Ford, your U of M. Now, generally, when people do that, they are donating to a family member or a very close friend, but there's also something called altruistic donation, which means I don't know you, but I know that you need help and I want to help you. So that's also something to consider as well. If a person decides that joining the registry is right for them, they're going to have a red heart with the words donor on their driver's license or their state ID. And that information is kept in a confidential database. I can't go back to the office and say, I wonder if Heather is a registered organ donor. I don't know how to do that, to be completely honest, because I don't need to know how to do that. The only time that database is checked is when a person passes away. And we go from there and we see what organs and tissues could be viable and possibly save someone else. Most people do sign up at the registry, but you can also go to our website, golom.org. Also on that website, you're going to find a lot of facts and statistics about donation and also inspirational stories. And you can see what sort of cool things we're doing across the state as well. So as I said earlier, there are a lot of myths about donation. A lot of times people will say, well, I can't be a donor because I'm too old or I'm too young. And that's not true. High schoolers, they're under the age of 18, but when they get that learner's permit, they're going to be asked if they would like to join the registry. One of our oldest donors was a gentleman who was 92 years old. He was able to give his liver to a woman in her 60s. Just last summer in the Detroit area, we had a woman who at the age of 101 years of old was able to donate her tissue. So please, please, please do not count yourself out. Age is not going to be a factor for joining the registry. Same thing with medical conditions. That's another thing I hear. I have this, I have that. Well, most people have a little something going on with them, but that does not prevent you from joining the registry. So for instance, let's just say this was the year 2013. If someone was HIV positive, they would not be able to donate. But just last December, we passed something called the HOPE Act, which stands for HIV Organ Policy Equity Act, which allows people who are HIV positive to donate to other people who are HIV positive. So science and medicine are constantly evolving. Something that you think would not make you a good candidate right here in 2023, maybe 30, 40 years from now, you won't think twice about it. So please do not count yourself out. Like I said, the 4 biggest myths, people have this fear that they're not going to get great care. We already discussed that. All major religions, Christianity, Islam, and Judaism support donation because you are saving or healing the life of someone else. And that is the most loving thing that you can do. There's no cost to your family to be a donor. Gift of Life is going to absorb that cost, nor is donation going to affect your funeral arrangements. If you would like to be cremated, fine. If you would like to have an open casket funeral, not a problem at all. We don't leave you looking like Frankenstein. There's a good chance you've gone to a funeral of someone who was a donor and you had no idea because they looked like themselves. So any sort of funeral custom you would like can still take place. So please have this conversation with your family. Death is really, really hard, really, really stressful. And this is just one less decision that your family has to make at a really difficult time. Find out where your family stands on donation as well. I always encourage people, if they are going to join the registry, please don't keep it a secret. Make sure whoever will be speaking for you when you can no longer speak for yourself knows what your wishes are. This right here is Hartley. Hartley is our chief mascot. You can find them on the Tick and the Talk. And you can also find us on all of the social media pages so you can see what sort of cool things that we are doing across the state to promote donation. Now, I have a very, very, very special person with me today. Her name is Miss Sonia Cook, and she is a kidney recipient. Now, I can drop facts and figures on you all day long, but I don't think it has half the impact of someone who has actually walked the walk and made it to the other side. So I'm going to stop talking and I'm going to turn it over to her.
Good afternoon, everyone, and thank you so much for joining today. I'm going to share my story with you. I know that 10 minutes or 20 minutes could not tell you how thankful I am, but I'm going to share with you as much as I can today about the selfless choice and act that a family made for me. 18 years ago, I received a kidney transplant from a 2-year-old that passed away from complications of the flu. Before I get into my story, I'd like to tell you a little background. 20 years ago, I had a daughter that was born severely premature. Her name is Naya. Naya was born at 5 months. She weighed 1 pound, 1 ounce. She was born at 23 weeks gestation. Approximately maybe 2 years before I had Naya, I found out that I had an underlying kidney disease, which was called IgA nephropathy. How I found out that I had IgA nephropathy was I had been suffering from a headache, which I never suffered from headaches. So I left work early and went to my PCP. When I went to my PCP, my blood pressure was elevated. My PCP knew that my blood pressure was never elevated over the years, and she was truly concerned about it. So she took a lot of blood work. Blood work came back that my creatinine level was up. So the next thing that she wanted to do was to send me to a nephrologist. They did a lot of work for me, a lot of blood work on me, and determined that I had an underlying kidney disease called IgA nephropathy. Before I became pregnant, my doctor explained to me that if I was to get pregnant, that I may end up with preeclampsia. When I did become pregnant, I did not end up with preeclampsia. I ended up having I ended up having, a high-risk pregnancy. So during a high-risk pregnancy, I went into labor at 3 months. When I went into labor at 3 months, I went to the hospital with urinary retention. They don't understand today why I had the urinary retention. The urinary retention ended up putting me on bed rest. So I had to go on bed rest at 3 months. And at 5 months, I went into labor. When I went into labor and they took Naya, I lost all kidney function. They did not realize that I had lost all kidney function until a few days after my delivery. I kept telling them that I was having back pain, I was having abdominal pain, and my urine was not coming out like it was supposed to. It was my first child. They told me I needed to get up, I needed to walk. Basically, they were telling me that I was a wimp. You know, the staff was like, you just need to exercise more. There's nothing wrong with you. But there was something wrong with me, and I knew it was something wrong with me. My nephrologist was out of the country at the time, and they were about to discharge me. I hadn't urinated like I was supposed to. I was in this severe pain. They came in, they told me, Ms. Cook, you're going to be discharged today. I said, I cannot be discharged today when I know that something is truly wrong with me. So the doctor says, well, I'm sorry, but you have to go. So I said, well, I'm not leaving. You're going to have to call the police on me. Until you take my creatinine level, my BUN level, and find out what's going on, I'm not leaving here. So he came in, he said, okay, I wrote the orders, but after your orders come back, then you're discharged. When he came back, he didn't even come into my room. He stood at the door and he says, I'm sorry, but you're in total kidney failure. We'll send a nephrologist to see you. I broke down. I had no idea. I had just had a premature baby that was on life support that weighed 1 pound, 1 ounce. She was born at 23 weeks. I couldn't even see her because she had so many tubes in her. So now both of us are fighting for our lives. I automatically said, please give me access, jumpstart, see if you can jumpstart my kidneys, do whatever you need to do. They called a nephrologist in, the team came in. They gave me access. They put an access catheter here. They started me on dialysis. My kidneys didn't do anything. They were still failing. So now I need access in my arm. They give me a graft in my arm. I'm going from all of these surgeries, all of this access, and I'm still trying to see my child, pray that my child lives, that I live to see my child. I fast forward. I get out of the hospital. I'm on dialysis 3 times a week, Monday, Wednesdays, and Fridays. I've never experienced this a day in my life. I don't know anything about transplantation. My family has always said we were born, the things that we were born with, we're going to leave here with them. They didn't believe it. If it was not for my dialysis techs, I probably would still be sitting on a machine. They said, Sonia, did you join or did you get your workup for your transplant? I said, no, I didn't know I was supposed to. I don't know anything about it. I said, plus my daughter is in the intensive care unit. I have to see if she's gonna make it. They say it's not like getting a pair of gloves or, you know, a new coat. There's a process to this. When you leave here today and you get off of this machine today, we need you to go talk to the social worker, your nephrologist and everything, so that you can get a workup to see if you can get on a transplant list. And that's what I did. Fast forward, my daughter stayed in the NIC unit, the neonatal intensive care unit, approximately 6 months. I stayed on dialysis approximately almost 3 years before I received that call. My daughter was 2 years old. When I received that call, it was about 3 in the morning. And my coordinator said, Sonia, we have the gift of life for you. A 2-year-old baby has passed. I said, oh, I can't take kidneys from a 2-year-old baby. She said, yes, you can. I said, no, I can't take it. It took 3 calls for my coordinator to convince me that I had to take this to stay alive and to be here for my daughter. I received the gift of life from a 2-year-old baby. Her name was Lynn May. Lynn May passed away from complications of the flu at 2 years old. Lynn May was born in China. She was adopted by a couple in Dearborn that made the selfless act to donate her organs to save my life. I received both of her kidneys, and on 3/5/05, they were donated to me, and it's been 18 years. I thank God, I thank Lynn May, and I thank Lynn May's family. I share my story with each of you, hoping and praying that you share with your friends, your coworkers, your families, and get as much information as you can, because it has changed my life. Thank you so much for being here today. God bless.
Oh my goodness, what an amazing story. I brought on Nurse T because she's gonna take us through, she's gonna talk about kidneys for a little bit, but Sonia, Shalana, we have to have you back. We have to hear about what happened after your transplant, what the transplant was like. We want all of the details. So please, let's set you up to come back in the next few weeks, and we will continue this story, continue to hear the next chapters. And we've got questions going like crazy in the Q&A. We just can't get to them because we have to turn to Nurse T and then turn to Dr. Lira. So So Nurse T, I don't know that we have time to go through your slides. You were going to talk to us about kidneys. What should we know? What are the key takeaways?
The key takeaways, can you guys hear me?
Yep.
Okay. Would be knowing how to manage your hypertension and diabetes. Unmanaged, uncontrolled, undiagnosed hypertension and diabetes can lead to kidney disease. Being familiar with some of the signs and symptoms as far as decreased urination or increase, knowing your blood pressure, your results. It's a lot of different things that you can do and know as far as kidney health information. And I know we're short for time, so you can reach out to me later and I'll make sure everybody get a newsletter on kidney health. Understanding that your kidneys are responsible for filtering waste through your body. And when they're not able to filter waste, then there becomes a buildup. So just being familiar with kidney disease, what kidney disease is, understanding the 5 stages. When she was talking about, she was in end-stage renal disease, which we call stage 5. It's important to know that when a lot of times kidney disease is a silent killer, by the time we find out about it, we're at stage 5. But what we did see is some hope, and knowing that if you do get kidney disease, that your life is not over, all is not lost. You can still bounce back, heal, and win with research, resources, information, and following up with your physician. So.
And what about, I have to admit, I took a peek in your slides. And one of the things that you mentioned was a GFR. Can you talk to us about that? And I see that Dr. G put a nudge in the Q&A for us too. So it's important to her too.
Yes, can you just put that slide up right quick, just so I can reference it?
For sure.
Yeah.
Oh, I'm going to have to show all your business though, if that's okay. All of your slides, hang on.
That's okay. Let me see, we got what? So maybe we can just go through them in 3, just slide them through.
Okay.
So your kidneys are the king of kings. Next slide. The kidneys are 2 bean-shaped organs. Each kidney is about the size of a fist. Next slide. The kidneys are responsible for filtering waste, which we talked about. Next slide. Kidney disease happens when your kidneys are damaged and can't filter blood the way it should. We talked about that.
And different kidney problems, cysts.
And different kidney problems, kidney injuries, cysts, and sometimes kidney stones will put you at risk for kidneys. We mentioned high blood pressure, diabetes, heart disease, obesity, family history of chronic kidney disease, being familiar with your family history, past damage to the kidneys, and older age. Next slide. Chronic kidney disease means you have lasting damage to your kidneys that can get worse over time. And I think the next slide will talk about the GFR. When your kidneys are damaged and lose the ability to filter waste and fluid, that's how that little bean is looking. It's sad, upset, and needs some help. We can go to the next slide. So when your estimated filtration rate, which we call the GFR, falls below 15, indicating that your kidneys are failing or close to failing, treatment like dialysis or kidney transplant will likely be needed to prolong life and keep your body health and chemical balanced. Next slide. Here's what the treatment options look like. To the left of me is the dialysis, and to the right is the kidney transplant that they're doing. Next slide. It's usually silent until about stage 5. Next slide. Those are just some of the signs that if you have, that you can go to your physician: nausea and vomiting, fatigue, shortness of breath, swelling in your hands, legs, and feet, metallic taste in your mouth, muscle cramps, trouble sleeping, itchy or irritated skin, but it's really, you're really itching. And then too much or too little urine. Next slide. I think it's, next slide, we can go to the next one. African Americans are almost 4 times as likely as whites to develop kidney failure. Next slide. Know your GFR. GFR is a measure of how well your kidneys filter blood. It's estimated how much blood passes through the glomerular each minute. A GFR of 60 or higher is in the normal range. A GFR below 60 could mean kidney disease. A GFR of 15 or lower may mean kidney failure. Just because you go to the physician and you have a low GFR, please do not panic. Just make sure that you follow up with your physician and have them discuss some options with you. How kidneys are checked, they check the blood test for your GFR and then also albumin in your urine. So you will be asked, to have a urine test. Next slide, and I think that's about it. Understanding your treatment options, which we've all went through that. Another option is peritoneal dialysis, which we can talk about that a later time. Chronic kidney healthcare tips, we will put them in the chat. One thing though, manage stress, understand your options, and make sure you take care of your medicines as prescribed. And we had a healthy good time. So I think we went fast, but if there's any information that anybody needs, just please reach out to me or reach out to Heather, and we'll make sure that you get the information, and we can always come back at another time and go a little bit slower. So thank you.
That's right. We'll get you taken care of. All right. Thanks, Nurse T. Slid it right in. Now we're going to invite Dr. Caitlin to join us. She's going to continue the conversation around STIs. I think we've got some time. You have new data, and so we don't want to miss the new data. We also have some questions, Dr. G, if you're available and you want to come on and ask that. But let's take a look at the data that you have.
For sure. I'm just going to put my contact info here in the chat. If anybody has any questions and I talk too much and run out of time, please feel free to email me. Also, one quick non sequitur, just building off of what Sonia shared and Nurse T shared, is I'm a big believer that patients need to be advocates for themselves. So if you or your family members are on dialysis, ask your doctors about the possibility of transplant. Sometimes from the provider side of things, you spend so much time getting someone out of a crisis period where they maybe started on dialysis that it may not be, top of their mind. So advocate for yourself. You can always ask. There is a process and there are selection criteria, but if you don't ask, you'll never know. So I just want to emphasize that. And then, without further ado, let me share my slides. Okay, so I am going to talk more about STIs today, and I just really wanted to emphasize that when we talk about STIs, we will be talking about different prevalence in different communities, and this prevalence is not a sign that people in certain communities are engaging in riskier behavior or somehow unclean. These patterns tend to follow other barriers to care and other issues with access. So as we talk about this, the broader conversation needs to really be about how do we get people the care that they need, and in so doing, reduce stigma for these types of infections. So just a quick update, in Genesee County, there has been a really significant increase in syphilis, and it is significant when compared to the rest of the state of Michigan. There has been about a 92% increase overall in syphilis cases, whereas in the state of Michigan between 2021 to 2022, there was only about a 5% increase. So this is a significant jump. There was 122% increase in primary and secondary cases, which are the most transmissible. In absolute numbers, that went from 18 cases to 40 cases, and overall from 62 to 119 cases. This is the highest case rate that we've had in Genesee County in about 10 years. And the groups that are most vulnerable tend to be individuals between 20 to 29 years old and African-American men. However, there has also been an increase of 42% in heterosexual males and 75% increase in heterosexual females. Just a quick review, there are multiple stages of infection with syphilis. Primary syphilis is characterized by, really can be asymptomatic. It's really the secondary stage that has a diffuse rash. Sometimes with the primary stage, you'll see a small sore at the site of contact, but it's really the secondary stage where people develop fevers, chills, rash. Early latent syphilis tends to actually be asymptomatic. After the secondary stage, many people clear those symptoms and then are asymptomatic, but may still be transmissible and carry the infection. And that lasts for about 12 months from initial infection, and then late latent disease is any time beyond that. So in general, the populations that have the highest prevalence of this disease is gay and bisexual males, followed by heterosexual males, heterosexual females, and people who inject drugs. Again, there is a disproportionate prevalence of this infection among Black and African American individuals. However, it does affect all races. While men make up the majority of syphilis cases, the proportion of patients who are female is going up. And why this matters, not just because women matter and women are being affected, but there is an increased risk of congenital syphilis when reproductive age women contract syphilis. And congenital syphilis can cause abnormalities in a fetus that will last their whole life. So really prioritizing this group, heterosexual women, women of childbearing age, and pregnant women for screening and treatment of syphilis is essential to get a handle on this. I'm just gonna, okay. So here, this is the chart from the Michigan Department of Health and Human Services, and it is outlining the screening recommendations for all pregnant individuals. So all women at first trimester should get HIV screening, hepatitis B screening, hepatitis C screening, syphilis screening, and chlamydia and gonorrhea. And then early third trimester, they should be retested again for HIV, hepatitis B, and syphilis. Individuals who have other risk factors, and these risk factors include having had an STI at any time during pregnancy, history of injection drug use, a sexual partner who injects drugs or shares equipment, a partner with HIV or STIs, a new partner or more than one partner, or women who engage in transactional sex should all be tested again for chlamydia, gonorrhea, hepatitis B, hepatitis C at 36 weeks, as well as HIV and syphilis. Given that this is such a broad group, I will tell you practically in our clinics, basically everybody gets tested again at 36 weeks. If an individual has no prenatal care and kind of just presents to the hospital at any time, they should be screened for all of these STIs. HIV, hepatitis B, hepatitis C, syphilis, and chlamydia and gonorrhea. Earlier, there had been a question about the difference between the terminology. STD stands for sexually transmitted diseases. STI stands for sexually transmitted infections. They're the same. I think it was more of like a public relations thing when people started going from using STD to STI, because infections are treatable, whereas diseases are often seen as like a chronic process. Another question I've received related to the safety of acyclovir in pregnancy. I want to emphasize more than anything, even if you don't read any of this slide, that acyclovir is safe in pregnancy. It does cross the placenta and it is present in breast milk. One of the limitations with any medication for pregnant women is that nobody conducts studies looking at effects of these medications in pregnant women, because if there is an effect on the fetus, it's pretty catastrophic. So a lot of the data that we have to look at medication safety in pregnancy tends to be, looking back retrospectively at like how many women were on acyclovir and how many babies born from those women developed birth defects. And in this case, really, the risk is very, very low to minimal to none. There were multiple observational studies done. A large cohort in Denmark looking at almost 2,000 pregnancies found no increase in congenital abnormalities. And then another cohort done a little bit earlier of over 1,000 pregnancies also showed no congenital abnormalities. Acyclovir is recommended by the American Association of Obstetrics and Gynecology, which we call ACOG. And they recommend acyclovir in pregnancy for primary HSV, which is herpes simplex virus. An outbreak in pregnancy, if it's the first time you've contracted it, can lead to fetal abnormalities. So treatment of the herpes simplex virus, it decreases the duration and the severity of the disease. So the benefit of treating it is greater than the risk of getting it and not treating it. Suppressive therapy, so this is recommended for anybody who has history of genital herpes or oropharyngeal herpes, should actually be put on acyclovir at about 36 weeks of pregnancy, because if someone has an outbreak at time of delivery, it can be passed to the infant. So that antiviral helps decrease the risk of an outbreak at the very end of pregnancy. And acyclovir is also recommended for the treatment of varicella, which is the virus that causes chickenpox in pregnancy. Some other questions I got related to the human papillomavirus, and I'm very excited that people ask me about this because it's really, really important. It's one of the few STIs that we have a vaccine for, which is pretty remarkable. So overall, this virus is very, very common. There's about an 85% lifetime prevalence in anybody who's been sexually active. At any given time, about 45% of men and 39% of women have this virus. It's universally asymptomatic, so people may not even know they have it. The way that most people find out they have it is either women are told that it's present on a pap smear, or someone develops genital warts, which are also caused by this virus. Most of these infections are cleared naturally by the body within about 12 months, but if it is present, like if it is present on a pap smear after 12 months, there is an increased risk of cancer. So your doctor may want you to follow for more frequent screenings. The virus, even though it's mostly cleared, it can stay latent, which means it can stay in the body and kind of be asleep and then reactivate at various times and be unpredictable in that way. So it's really important when we talk about this virus to understand what the risks are. There's different types of the virus. These numbers just signify kind of the different subtypes of it. The highest risk for cancer are subtypes 16 and 18. And then there are many low risk subtypes of the virus, with subtypes 6 and 11 contributing to genital warts. As far as the relationship between HPV and cancer, it's a very significant one. 91% of cases of cervical cancer are caused by this virus, 91% of anal cancer cases, 63% of penile cancer cases, 75% of vulvar cancer cases, 63% of vaginal cancer, and then 70% of head and neck cancers are caused by this virus. So it's really, really important to get the word out about this virus and the opportunities we have to try to combat it. So the American Association of Internal Medicine and Pediatrics recommends the HPV vaccine beginning at ages 11 to 12, but it can actually be given as early as 9 years old. Catch-up vaccination is actually recommended up to age 26. It's recommended to be given so young because this vaccine has the highest chance of being effective if it's given before someone is sexually active. Other groups that also should consider getting the vaccine are healthcare workers. If you work doing, pap smears, procedures such as like colposcopy during, cervical exams, or if you work in an ENT clinic that does a lot of head and neck cancers, some of the procedures can cause the virus to go into the air. So there is an increased risk for just people who work in these settings to get the HPV virus. So they should also be vaccinated. The vaccine is actually approved up to age 45. And I really want to emphasize this because even if someone has been sexually active, they will get some benefit from the vaccine. It's not as effective, but it still helps to reduce the risk. And so this group of people is really important to target. It's actually probably safe forever, but those studies haven't been fully done. So it's really only approved by the FDA up to age 45. I recommend offering it to anybody who's sexually active. I think that, as we saw, there is such a significant association between this virus and so many cancers, and you can get it not just from sex, but from close skin to skin contact if you're one of these health workers. And so I really think that we need to, take out the stigma from this vaccine. I know a lot of people feel that it's complicated to give a vaccine for a sexually transmitted infection to someone so young. But I would just emphasize that there's other ways to get this virus and that, you really just want to maximally protect someone. It is generally a 2 to 3 course vaccine. If between ages 9 to 14, it's a 2-course vaccine. And then beyond 15, it's a 3-course vaccine with doses at time 1 and then 2 months later and then 6 months. There are 2 different types of the vaccine. I recommend the 9-valent vaccine. It protects against more of those different forms of HPV, but there is also a 4-valent vaccine. Both vaccines protect against 16 and 18, which are the main cancer-causing types of HPV, and against 6 and 11, which are the ones that mainly cause genital warts. This vaccine is effective. So a decade after vaccine introduction, prevalence of these subtypes of the papillomavirus 6, 11, 16, and 18 decreased 86% among females aged 14 to 19 and 71% among females aged 20 to 24. Now, this vaccine came out in 2006, so it may be something that older individuals may not have been offered. But as we discussed, because it's approved up to age 45 and most likely effective onward, it's something to talk about. It's something to ask your doctors about. Important caveat, though, is insurance doesn't always cover it beyond age 26. So if you do want to get it and are interested in it, talk to your insurance and see, what the cost is before you embark on that. Another question was about symptoms of STIs, and the most important point I want to make is that they're often asymptomatic, especially oropharyngeal infections are most commonly asymptomatic. And so that is where the role of screening comes in and why it's so important to follow up and get screened. If there are symptoms, they can be broad and wide ranging, from vaginal or penile discharge to pain with urination, vaginal or intermenstrual bleeding or bleeding with sex, skin changes in the genital area, including lumps, nodules, rashes, or sores, lymph node swelling in the groin, lower abdominal or pelvic pain, and then, late stage untreated sexually transmitted infections can lead to preterm delivery, spontaneous abortion or miscarriage, ectopic pregnancy, and infertility. Prevention, the best way to prevent sexually transmitted infections is barrier protection. So male condoms, and then the less popular but effective female condoms can really, greatly decrease the risk of all of these sexually transmitted infections. For HIV specifically, there are medications that can be used to decrease the risk of getting these infections, such as Truvada and Descovy, which are pills, and then sorry, I wrote Cabenuva, but I meant to write cabotegravir or Apretude, which is an injectable antiviral that can decrease the risk of HIV. Vaccination, the HPV vaccine, is a great and effective way to decrease your risk of human papillomavirus, genital warts, and those later stage cancers. And there is some accumulating data that perhaps antibiotics following exposure to condomless sex can decrease your risk of sexually transmitted infections. This was a study just published in the New England Journal of Medicine. I won't go into the details of it, but it's just to say that, we're always trying, we're always learning, and hopefully someday we have better options for people. As far as screening goes, screening is really easy. The easiest type of screening is actually done by a urine test that looks for the genetic material of the infection or the virus, and that's called PCR testing. And that can be done for gonorrhea, chlamydia, herpes simplex virus. That testing can be taken of the herpes blisters, Mycoplasma genitalium, and the HPV virus is detected on, pap smears using this type of viral testing. Blood tests can also be done. These look for antibodies or viral level, and these can be used to detect HIV, hepatitis C, hepatitis B, hepatitis A exposure, and syphilis. Cervical smear, so like a smear on a glass plate from cervical discharge, can look for trichomonas. And it's really important that all sites should be tested. If someone's engaging in oral sex or anal sex or vaginal sex, they should ideally be tested from all of those different sites, because as we discussed, there are commonly asymptomatic infections and you'll never know if you don't screen.
But that's such an important piece, because sometimes when you walk into a situation with your doctor, you aren't prepared for all of the things that you're going to experience. And so that is a wonderful reminder. We are out of time. So I'm going to leave everyone with a cliffhanger with treatment options. And I'm certain all of the questions that you have around HPV and timing, and we just need to have you come back. Or if you have a burning question, Dr. Leroff has kindly put her contact information in the chat as well as here on the screen. Reach out to her. You can also reach out to us. We will get you in touch with these marvelous speakers that we have the opportunity to showcase. I'm certain we are just scratching the surface of your expertise. And so more to come. We'll have to set this up for everyone as a regular session. So I'm going to close us out by asking you to please join us next week, subscribe to our YouTube channel, and follow us on Facebook. And we will look forward to seeing you next week for the Flint Community Webinar.